Happy morning to all the dignitaries, guests, delegates. National Institute for Empowerment of Persons with Multiple Disabilities, NIPMET Chennai, with an objective to upgrade the knowledge and skills of rehabilitation professionals practicing in the field of disability rehabilitation, organizes series of CRE programs. So NIPMET welcomes you all for today's one-day national level CRE webinar on the topic positioning and special seating in home and classroom for cerebral palsy children. With extreme pleasure, I extend a warm welcome to our director, Sri Nachiketa Raut sir, and our rehabilitation officer, Sri Gurumurthy sir, who have joined us today to inaugurate this webinar. We are honored to have you all with us, sir. I bid a warm welcome to all the eminent resource persons of today's CRE as well. I am so pleased to welcome all the participants. May I now request our respected director, sir, Sri Nachiketa Raut sir, to deliver the inaugural address. Over to you, sir.
Thank you, madam. Today we are going to have a national level CRE webinar on positioning and special seating in home and classroom. I was trying to understand the significance of the topic, and what I understood, by profession I am a speech language pathologist, so positioning is something which a speech language pathologist also needs to know, because the moment you are positioned appropriately, you can begin the process of communication. So when I was trying to understand, it was understood that if we do not position, if the child doesn't position himself or herself appropriately, especially in children with cerebral palsy, where there's a contracture and the child would be, would be would not be in a position to sit down, would not be in a position to roll over, would not be in a position to have have himself positioned on the elbow, or would not be in a position to stand with support, then what happens? What are the challenges that the child faces? The child would be facing, the first challenge would be that the child would be having the absolute difficulty in terms of doing basic activities. The child would be having challenges in terms of getting his or her bone density appropriate. The child would be having challenges that the muscles would not be growing appropriately and with the same strength. So the child would be slowly developing tightness, which may require a surgery later on. So it is very essential that the child is positioned appropriately. Once the child is positioned appropriately, the child starts using his or her hands, starts using his head to see things and explore things. So it's very essential that everybody, one and all, should be knowing what is positioning and how best we can position a child for the purpose of overall development. This particular webinar would be helping us to understand quite a number of things surrounding positioning. It's essential for one and all. I had requested our coordinator to develop a pamphlet where she shows this is the wrong way and this is the correct way of positioning. I can see that, yes, she has done a pamphlet where she's showing which is the wrong way and which is the correct way of positioning, starting from carrying, lying down, sitting and standing. So I think all of these would be discussed in detail in the webinar, and all of us would be having a good knowledge fest in understanding something which is very basic and fundamental. I once again congratulate the Department of Therapeutics to have conducted this particular program, a national level CRE program on positioning and special seating in home and classroom. I congratulate the convener, Dr. Santosh Khanna, and the coordinator, Smith Mercy Clara, Professor in Physiotherapy, Department of Therapeutics. Thank you one and all for joining, and I formally declare the program open. Mercy, madam.
Thank you, sir. Thank you so much. Thank you so much for your inspiring words, sir. So may I request you to release the pamphlet that we have prepared in the short notice, sir?
Now, can you upload it?
It's there in the PPT.
It's on my desktop, no?
Yes, sir. It's on your desktop.
Yes. So I'll just put this on, or I have to upload it?
Well, everything will be in presentation.
Where? Yeah. Yeah. How to share it?
Yes.
Yes, ma'am. Okay, yes, I hope it is visible. Is it visible, madam?
Yes, yes, sir.
Okay. This is the pamphlet which has been done, and here we can see these are the two positions which are wrong, and these are the two positions which are correctly done. Again, we can see a wrong position of lying here, and here we can see a wrong the correct position in which the child can be positioned in seating position as well as in lying position, so that the child can explore things. This W sitting is wrong, and the other part where both the legs are extended and are not in W position is the correct one. Similarly, standing, we can see how weight bearing is done, or how with support the child is standing, and this leads to appropriate positioning, reaching things, exploring things, bone density and muscular density. Okay, I think we can add up a few more examples to this, and by the end of this webinar, we will have one more sheet added to it with few more positions which are wrong and which should be correct. Thank you, Clara madam. Thanks a lot.
Thank you. Thank you so much, sir, for joining us. Thank you. Now we are moving to the scientific session, session 1. So I'm happy to introduce the resource person of our session 1, Mr. K. Yogarajan, sir, the Associate Professor in Physiotherapy, NIPMED, who has nearly 14 years of experience in pediatrics, sports, and neuromuscular rehabilitation. He is well versed in Bobath concepts, kinesiology taping, and he's also trained in aquatic therapy. So his topic is on assessment and problem solving approach to improve breathing and ribcage movement in various positions. Over to Yogarajan, sir.
Stop wasting.
Good morning and happy morning today for attending a CRE program. My topic is assessment and problem solving approach to improve breathing and rib cage movement in various positions. Okay, I will share the PPT. Okay. Is it visible of my PPT? Share. Hello? No, sir, not similar. Share பண்ணுவா திருப்பி ஷேர் பண்ணுவா ஷேர் பண்ணுவா Is it visible of my PPT of today topic? ಇರ್ಲಿ.
Yes, sir.
Oh,
Sir,
okay.
this is
Yeah. Okay, I can start with the introduction about respiratory movement. Before going for the intervention strategies for the children with breathing difficulties, let's start with the basic respiratory movement. For the normal inspiration and the expirations, the normal if you do inspirations and the expirations, the normal of breathe and an adult normally for 15 to 20 pulses per minute, and then if the increase with exercises, body temperature and certain diseases. For the newborn babies for 40 to 50 minutes, and then for the sleep respirations, and then due to emotions the respiratory rate is differ. For the CP children, most of them they are affected with the breathing. Why their breathing is affected? It's due to developmental delay and also some of the missing of the milestones and the lack of head control. They are not achieving for the proper writing reactions, equilibrium reactions, and also productive reactions of the head, and also some of the missing of the reflexes that will affect the baby's alignment of the trunk. If you due to lack of alignment of the trunk, the breathing and the rib cage, everything will be different. The normally for the newborn baby, the breathing is abdominal breathing. If the once the baby for starts for verticalization, for the baby comes for the prone lying position, the center of gravity shifted from the sternum. But initially, the sternum will be the base of reference point, and then progress to the some of the hip or the pelvis. Once the development of the moving from the verticalization develop, the baby will uh, starts to using of the respiratory muscles. So the first for initial for observation is very important. Introduction about this is the most important respiratory movement you have to assess during the baby is comes for the therapy. Okay, now breathing. Normally the breathing according to for the systems of breathing, for if you inhale of the breathing, the two movements are happening for the pump handle movement and also the bucket handle movement. For the pump handle movement, it increase the anteroposterior diameter of the chest, and also the bucket handle movement and increase the and lateral movement of the chest. Why this movement is very important for CRE topic. Hello. Message madam. Yeah, I'm continuing with the again with the mechanics of respiration once again due to some technical delay. Okay, for normal respiration, mechanics of respirations for the inhalation, the during inhalation the rib cage expands and the air draws in and the diaphragm pulls down. Other the mechanism is while during exhalation the rib cage pushes in and the air pushes out, diaphragm pushes in. This is the normal breathing mechanics of respiration. If there is any disturbed in the mechanics of respiration, some of the paradoxical breathing, if the child with any other developmental delay, the rib cage is flare, the baby their abnormal pattern of breathing method, there will be changes of diaphragm pushes out, and also diaphragm pushes out during inspiration, and also diaphragm pulls down during expiration. This will be change the mechanisms is completely collapse of the trunk. Okay, next the respiratory system. So the respiratory system is the basic physiology. Basic physiology of the respiratory system, the bronchi, bronchioles, ribs. What are the importance of each bronchi and bronchioles? Okay, ribs main function is to protect the chest. Alveoli, air sacs, mostly their gas exchange takes place. And for the trachea for any other trachea is the rib cage for to raise and lower the ribs, and also diaphragm, the muscle seats pulls the air into the lungs. Okay, the next slide. Functions of the alveoli. Gas exchange. For the gas exchange, if there is for the lower part of the alveoli, the small sacs in the lungs are surrounded by capillaries. It is in this alveoli that oxygen enters our blood and the carbon dioxide leaves. Alveoli are very good at exchanges gases because they have the large surface area, they have a good blood supply, and very thin walls. Okay, now the next slide is about the introduction of the thorax. Okay, thorax is main for this thorax. Uh, Important angle, the costovertebral angle. The 12th rib forms an angle with the vertebral column called the costovertebral angle. Kidneys lie here at 11th and 12th ribs. Right kidney sometimes palpable at between that it lies 1 to 2 centimeter lower than the left. Okay, diaphragm becomes arched during expirations. Okay, why this is a diaphragm becomes arched during expirations? Because your heart and lungs are protected by your rib cage. While okay, and then for the next the structure is chest wall is bony rib cage, manibrum, sternum. Okay, manibrum, sternum, 12 pair of rib, costal cartilages, and thoracic vertebrae, and then soft tissue covering muscles, neurovascular bundles, other connective tissues, two aperture, superior root of the neck, inferiorly separated from abdominal cavity by diaphragm. Okay, some assessment of the rib. For if the patient comes with you for any other developmental delay, basic assessment is from the supine lying position, you have to assess the neutral spine. From the neutral spine you have to head to toe assessment, the alignment of the head, and the head is the turn towards left and right, and alignment of the shoulder, whether the shoulder is one drop down or for one side and also the other, and also we could place your hands on the both side of the rib cage, and like, and just check for the expansion of the chest, whether the drawing in and drawing out, and also the anteroposterior mobility, and then you have to check the intercostal space and rotational mobility. For the basic assessment is supine lying assessment, general position. You have to observe the predominant patterns of this is all very important assessment for the normal people and also the abnormal people. Okay, for the child. Okay, for the general posture assessment is predominant pattern of activity, the baby predominant whether there's a flexion able to head rise from the supine lying position, the baby is head turned towards left and right, and then the baby is for the social smile to the parents or mothers, and also asymmetries, whether the head is alignment with the trunk or the head is tilted towards the left side and also the right side, and the head midline is straight line. Why the midline is important for the babies? Because if there is the lack of midline of activity of the child is due to some of the
vision disturbances are due to nystagmus, and also some of the main related vestibular system is affected. You have to look for the side the baby will uh, midline, the turn to left, the left, and turning the head left to right independently. And the arms, if you bring any objects in front of the arms, the baby will normally the baby will to bring to midline, and also the reaches forward. Legs, the independent uh, leg, if the free kicking of the leg of the movement. If the, sometimes if the baby, the normal, if there any developmental delay baby, sometimes the premature delay baby, the for the kicking of the legs, sometimes it will be missing, sometimes the overlapping of the milestone movement sequence. For example, using your shoulder, just lift the head up, the baby is in out of the positions, and also the rolling. Continue with the prone laying position, the same assessment. If the just to stimulate the child, don't touch the child, just to observe the baby will the predominant, whether their baby will move forward, and also with the use of hands or with the use of shoulders, or whether you can observe from the backside, other from the spine of the scapula, there is any scapula will be winging of the scapula, some of the medial border is raised. Okay, this is an asymmetries mostly it will be observed in the head is turned towards the left side, and there's also the alignment. Head midline left to turn right independently, the arms forearm support, extended arm support, weight bearing, free, and arm for reach appropriate weight shift, and independent movement. And also you have to check whether the baby movement sequences rolling left to right independently, or pivoting left to right, and 4 point kneeling, and also the crawling. Continue with the sitting position. Next line of assessment is the sitting positions. Why this is sitting position is important? From pull from sitting position, from pull to sitting position, from the supine laying, you have to assist and grasp with the hands. This is the baseline assessment, whether the baby is any other writing reactions, if they are not alignment of the head to the neck, and also if there is any, you can just observe for any head control or lack activities of why this type of assessment is important, because for anatomical train continuous from the head to toe, the baby developmental pattern of verticalization, and also the centralization, and also moving of the center of gravity from the sternal to the base of support of the S2 sacral vertebrae. Okay, if there is any disturbances in the head and neck also, it will be affecting the breathing pattern, and also rib cage pattern, and also the total trunk stability will be disturbed. And the head control, and also the leg activities of the leg, whether the dissociation, whether the activities of the leg is the free dissociation of the movements, or the baby will scissoring gait pattern. While observing the long sitting posture, where the pattern of activity, the baby will bottom shuffling using the buttocks, whether the baby will move forward or backward, and also the baby will alignment or symmetry, whether equal weight bearing on the buttocks, and also the free arm support, you're able to sit, or because sometimes the baby with the lack of trunk control, with the lack of abdominal muscles and the core muscle control, the baby will immediately lose the balance within 1 or 2 minutes. Okay, sitting on the bench, the gentle posture. Okay, the balance and saving reaction. Just to push from the backside, the baby will forward, and also sideways, and also the backwards. The next, why the uh, once we have basic functions of the respiratory system, we know about the basic functions of the respiratory system. What is the mechanics of the respiratory system? We will for the last for 10 slides about the basic physiology of the movement. What why this is necessary to, because this positioning and also the basic physiological movement is disturbed, your treatment strategy will be changing. Okay, for the first that's why you for the last 10 slides for about the 10 slide about the basic physiology. Now the treatment strategy. Now the musculoskeletal, respiratory, neurological affect the musculoskeletal part of, if there is a lack of breathing or control, if there is a decreased range of motion of the joints. அடுத்து இல்லை. Okay. Okay, and the next treatment strategy is about the musculoskeletal, respiratory, neurological, and these are all the main important systems will be affect the function of the postures. There is any good functions, cognitions is very important for the musculoskeletal fine. If the baby has a decreased range of motion of
Slide move ஆகுமா? Slide move ஆகுது. First slide ல இருந்து.
Are you audible? Okay, I'll continue with the treatment strategies. Okay, first start with the musculoskeletal, respiratory, neurological part that will influence the function of the postures. Okay, musculoskeletal. There is any decreased range of motion of the joints, and also the lack of some tightness in the muscles, and also some of the tightness in the rib cages, and also if there is the patient have some other difficulties in initiating movements, the breathing will be affected, and also the moving and reaching will be affected. The rib cage is the foundation of the movement sequence. The sequence, some of the movement will be creates lumbar and pelvic stability through the intra-abdominal pressure during an inspiratory cycle, which loads the pulmonary function and the work of the pulmonary function during the respiratory cycle. Now the treatment strategies. The respiratory diaphragm feeds the parasympathetic calming nervous systems, maintaining the balance of arousal and also keeping the anxiety in check. Okay, now the breathing pattern. First, what is the breathing? Basic. Start with the baby or any child or patient is a good respiratory pattern starts with the diaphragmatic breathing. The breathing there should be the equal amount of chest, belly, and also the lateral expansion. Ask the patient to one hand on the upper part of the chest or sternum and another hand on the abdomen. Tell the baby to full expansion of the respiratory muscles and feel the abdominal will be protrude in like a balloon, and then will be blows out through the expirations. Turn the head and also through blows out through the mouth. The baby the suck in of the abdominals. Okay, this is all the basic breathing pattern that tell the patient, or if the patient is good cognition, you have to encourage this breathing pattern of to feel the filling of the oxygenation, and also to improve the, because the patient has paradoxical breathing if there is any developmental delay. This type of breathing technique will be helpful for the learning the new movement of the learning the new skill movement of the chest and also the thorax. This new movement will help to activate the medulla oblongata. This is the medulla oblongata is the center of the respiration. Once the medulla oblongata is activated, you will get full oxygenation and also through the afferent impulses and also the efferent systems. Okay, the breathing full expansion of the respiratory diaphragm in three planes creates the maximal intra-abdominal pressure and full loads the pelvic floor. That is called the umbrella breathing. Next one is central stability. For the any central stability, the inner core muscles. What are the inner core muscles? Respiratory diaphragm, pelvic floor, floor, இங்கே பண்ணுறேன் ஏமாறல நெட்டு ஃபெசிலிட்டி இல்லையா ஸ்டாப் ஷேர்
Share. Share.
Okay, madam, this is the central stability. Once I finish the session, I can recall one more slide for okay, central stability. The inner core muscles, respiratory diaphragm, pelvic floor, transverse abdominis, multifidus. Initially, our central stability is provided by the physiological projection. For example, if I am sitting position, if forward to bend and reach the objects, the central stability will come in action for the working along with the coordination of the extensor muscles to maintain the central stability. Okay, the next some of the abnormal factors while seen with the cerebral palsy is postural compensation. Good postures with normal or neutral curves in the spine and extremities. Some of the postural stability compensation for the head and neck extension, end range to create stable base for the eyes negatively impacts the visual and labyrinthine systems. Okay, for example, the baby is lack of head control. There is a lack of midline of the head orientations to the trunk, and also there is no connection between the head and neck extension. The baby will develop only with the hey, maintain the position of head and neck extension. For the end range, maintain the head end range, it will be disturb the eyes to move the three-dimensional pattern to looking around the objects. That will impact the visual and labyrinthine systems. And postural stability compensation, posterior stability compensations, posterior pelvic tilt, and the end range to create the stable base of strength. If there is any posterior pelvic tilt, but the baby has some of them they are sitting with the lack of anterior tilt, due to lack of some of the abdominal muscles, the baby will the thoracic kyphosis, and also the baby lack of lumbar curve, that will impact the posture. Impact why the impact, how do you impact the posture? It will be affect the upright trunk posture. Okay, and the next is postural stability compensation shift of rib cage cause significant changes in thoracic kyphosis and pelvic tilt horizon. According for this is the author, they describe this postural stability compensation shift of rib cage cause significant changes in thoracic kyphosis and pelvic tilt. Next, postural stability compensation ribs. Okay. Okay, the next slide is about the what is the importance of alignment. Why the alignment is important? To feeds the activation of the inner core musculature, and the activation of the inner core continues to be feed alignment. For example, for the previous slide, we already seen some supine assessment for pelvis, rib cage, breathing pattern, core alignment, umbrella breathing. These are all the mandatory for to achieve the alignment. If there is any deviation of the pelvis or the rib cage, for the rib cage, if there is any lack of movement of the anteroposterior thorax of the anteroposterior, and also lateral movement of the thorax and the rib cage, that will affect the breathing core and the core alignment. Okay, for the quiet breathing, only the diaphragm and the intercostal muscles is responsible for the inspiration and intake of the air. For this activities will be increased activity levels of heavy work, play, speech, and recruit accessory muscle. During quiet resting respiration, this inspiration involves contraction of the diaphragm. Expiration results primarily from relaxation of the diaphragm and accessory muscles. This the pull of gravity lowers the rib cage, which helps compress the lungs. Okay, some how to improve the postural alignment of the baby or any other with abnormal motor development. First, you have to increase the respiratory diaphragm, and next point is to improve the transverse abdominis, and also to increase the activation of the pelvic floor muscles, and also to increase the function of the multifidus muscle. All thing happens only through the activities in the therapeutic ball. Okay, now the implications for treatment. Implications of treatment for any activity, you have to along with synchronizing with the breathing pattern to be effectively modulating the state of arousal. For example, if you any other plan for any other activity or program along with the breathing pattern. For example, if I want to raise the hands along with the breathing in, and also I have to lower down the hands with the breathe out. This is the synchronization of this activity will be effectively modulating the state of arousal of the child, and also the baby any other child will be developed willing to participation. It's due to can activate the medulla oblongata center. Okay, in treatment, one might use respiratory activities. For example, if there is any blowing activities, all the activities mostly they have to uh, progression towards the sense of midline and facilitate the tone and awareness of the postural muscles. And the next activity you have to design for the spinal stability and the rib cage mobility. Okay, what are the types of because these are all the for the physiotherapy for perspective. These are all the muscles mostly will be impaired. You have to address this some of the musculature. This activity is only be done by the physiotherapist known about the some of the biomechanical concepts and of the some of the myofascial trigger releases. These are all the some of the muscles energy technique. Shoulder musculature, what are the important muscles they are affected with the baby with any abnormal motor development, if there is any for the chest or chest muscles and also respiratory muscles, some of the supra subscapularis muscles, and also the uh, other pectoralis minor muscles, serratus anterior and biceps major, and also the trapezius muscles. Okay, if there is any weak pectoralis minor, if there is the patient with what will happen, the baby with head and neck the extended position with the end range extension, they are not able to visually gaze the object, and also not able to turn the head to right independently. Okay, if you stretch that particular some pectoralis minor muscle, you have to strengthening the pectoralis minor muscle, the baby with alignment of the head is to improve. Okay, next is breathing exercises. Diaphragmatic breathing, already I shared the slide about the sitting position. This is the basic uh, methods of training. Okay, lie on your back on a flat surface in a bed with your knees bent and your head supported. You can use a pillow under your knees to support your legs. Place one hand on your upper chest and the other hand just below the rib cage, and ask the patient to breathe in, and you have to fill the air, that's the balloon like blowing of air, and also in the abdomen, and you feel the abdomen of like bloating, and then while expirations you feel the diaphragm expression of the air, and also the suck in of the abdomen. This is the normal abnormal breathing. You have to do along with the synchronous breathing for 3 or 4 times. You have to learn the skill of training with 3 repetitions, 4 repetitions, 5 repetitions, and then day by day improve. And then you have to uh, after the 1 month progress of 2 sets and 10 repetitions to increase the vital capacity of the lungs. Okay, assisted lateral costal breathing technique. This is about the lateral costal breathing technique to improve the lateral expansion of the chest, because the baby for the child with abnormal development, most of the ribs are flare, and the baby only with the paradoxical breathing. For this respiratory breathing to be increase the sense of awareness about the ribs cage, and also the lateral expansion of the chest to for to promote the proper inspiration and also the expiration pattern of breathing. Okay, these are all the techniques for this is overall my slide. I can recall one more times about my slide for the 5 minutes. Okay, this is the topic about the assessment and problem solving approach to improve the breathing and ribcage movement in various positions. Please, basic first slide is about the introduction about the respiratory movement, how the inspirations occurred during breathing pattern, and also normal of breathe adult is 14 to 20. Breathing pattern is increases with the exercises, body temperature and certain diseases. For the newborn is 40 to 60, and the sleep the respiration rate is also improved. The breathing, normal breathing, inhale and also expirations, and also breathing. For the breathing, the diaphragm is the chief muscle of respirations during quiet breathing. And the mechanics of respiration is, if there is without basic knowledge of known about the physiology of the systems, if you are not treating the patient, if you're treating the patient without knowledge of this is your treatment is, you are not getting the proper outcome of the treatment goal. Okay, medulla oblongata of the brain, the regulating the respiratory system for the inspiration and expiration, and physiology of the respiratory systems, functions of the alveoli, and introduction of the thorax, and also the rib cage is the basis of the any other foundational of the upper limb movement. Chest wall mobility. Chest wall mobility for the diaphragm becomes arched during expiration. Okay, your rib cage, you have 12 pairs of ribs that are curved bones, your heart and lungs. Okay. Structure of the chest wall. as a therapist, or if there is any rehabilitation professional, these are all the basic some of the functions of the respiratory system, physiology of the respiratory system, and also function of the thorax before treating the patients. Okay. Okay, assessment of the rib. Now come to the treatment strategies. Okay, neutral spine. If there is any, the baby is sometimes with the scoliosis, or the sometimes with the kyphosis, sometimes thoraco lumbar lordosis. If there is lack of some of the arches in the spine. Okay, if there is any lack of arches, the baby, the breathing pattern is impairment of the breathing pattern. Okay, so first you have to assess the neutral spine, anteroposterior mobility. First to observe without touching the child, and after that you have to touch the child, and then look for the movement. And then after that you have to feel the movement, whether the baby is doing proper way of breathing. Look, feel, and move the baby, and then assessment of the rib cage. General predominant of activity, whether the head is turned towards left and right side, whether there is any asymmetries, alignment, midline, and also the prone positions, sitting positions. Treatment strategies, first basic treatment strategies, you have to promote the breathing pattern. First line of treatment is diaphragmatic breathing pattern. You have to teach the baby of proper way, the weather way of pattern with inspiration and expiration. Because the baby will learn the new skill movement, because due to prolonged lying position with quadriplegic or spastic diplegia, they will do the wrong way of pattern of the movement stored in the brain. You have to change the new movement pattern through the proper way of breathing technique. Okay, moving and reaching. While moving and reaching, we can encourage breathing pattern for the respiratory diaphragm, and some of these are all the physiological. Okay, treatment strategies. Breathing pattern, start with the supine laying positions, progress to the uh, sitting position, and then uh, standing positions. Central stability, how to improve the central stability through the therapeutic ball exercises, and also the use of assistive devices, prone on the bolster, prone on wedge, and using a pillow. Some of these are all the postural compensations we have to seen in the child with any other developmental disorders. Okay, some postural stability compensation, because the first for the right corner, if the top of the some of the posture is like the head is protruded forward, thoracic kyphosis, and also the pelvis is not because some of the compensatory shift, it will be affect the rib cage movement. If you continues prolong this posture, milligram of spindles, and in the thoracic area, and also the cervical area. If there is cervical is not alignment, if there is no muscle spindle activation, that the baby is not attained head control. Because for the first 5 years, most of them they are a neural dominance. After 5 years, some of the musculoskeletal dominance will happen to the child. The baby develops contracture. So you have to address the baby with initial breathing. You have to improve the breathing pattern. If the breathing pattern is affected, you have to refer to the any therapist. The therapist will do any other myofascial release technique, and also the core muscle exercises. And the core muscle exercises that will helpful to increase the trunk stability. The baby will attain the gross motor functions very early compared to the delay of the development. Okay, quiet breathing, postural alignment. Okay, if there is any doubts if there is any scenario, you can just put in the chat box. Please post your any questions in the chat box. I will show you. Okay. Some of them asking about the umbrella breathing. For example, the breathing, while breathing, full expansion of the respiratory diaphragm into three planes. For the three planes creates the maximal intra-abdominal pressure and fully loads the pelvic floor. That is called umbrella breathing. Once again, I can repeat: breathing full expansion of the respiratory diaphragm into three planes. For example, antero, posterior, and lateral planes creates maximum intra-abdominal pressure and fully loads the pelvic floor. This is the umbrella breathing. In the technical term, we call it as umbrella breathing. Sometimes, if there is any one plane is affected, the baby will go for the paradoxical pattern. Any other doubts?
Can breathing will cure with physiotherapy? Can breathing will cure with physiotherapy?
Yeah, for okay, one of them they're asking about whether the breathing will yeah, breathing will cure with yes, yes, because if for example, if the baby comes with you, if there is any lack of some abdominal control, if the lack of gut control, sometimes it will initiate the normal breathing with the, for example, in neurodevelopmental therapy, we facilitate the some of the sweep techniques around the diaphragmatic breathing that will improve the inspiration and expiration. Well, surely for if you start with the early stages, the baby with the physiotherapy techniques, for researchers, up to researchers studies, for 70% of the baby will improve with the breathing pattern. Any other doubts, madam? Hello, any other doubts?
Thank you so much, sir. Thank you for the wonderful presentation. So with this, we'll move on to the second session. So the second session, it's a great privilege for me to introduce Sri Gurumurthy sir, the Rehabilitation Officer in Therapeutics, NIPMED, Chennai. He holds a post-graduation degree in physiotherapy, neurology, and he also holds master's degree in social work and also post-graduation diploma in developmental rehabilitation. He has almost 20 years of experience in field of rehabilitation, providing outstanding healthcare to the disabled kids. So he's a proud recipient of various awards, including Best Contribution Award for Maldivian Community, UNICEF Project, and also Best Employee Award from NEPMED. So we feel happy to have him here. Over to you, sir.
Thank you, ma'am. Thanks for the introduction. Can you check my voice is audible and the slide is visible?
Yes, sir. We can see your slide. Slide is visible, sir.
My voice is audible, ma'am?
Yeah, voice is also audible, sir.
Okay.
Please proceed.
Thank you so much. Very good morning to honored all present here. It's a great honor for me to present the topic for the CRE program on positioning and seating devices in the classrooms and the home environment. So majority of the rehabilitation professionals will be dealing with the developmental disabilities. So cerebral palsy is one among the disabilities commonly we have to address as the rehabilitation professionals. Majority of the children will be at whether it is a home or someone is put in the chat box, voice is cracking. Is my voice clear or
Yes, sir. We can hear you.
saying it's breaking? Voice. So as actually I am here to share the topic on gross motor functions, how to facilitate, how to make it easier way for cerebral palsy. So cerebral palsy, almost the word cerebral palsy is a motor disorder occurs due to damage to the developing brain. So for children, how we are that for gross motor means it is a coordination of larger muscle group. Shall I just a second? Right. Now is it audible, ma'am? Is it the voice is clear? Still the participants are sharing the
Yes,
voice.
sir. Better now.
Oh, fine, ma'am. Thank you. So first let me explain about what is gross motor function. So gross motor, it is a coordination of larger muscle group. Once the coordination of larger muscle groups is a major role like a head control or sitting, standing, walking, running, all those things comes under gross motor functions. Why do we talk about gross motor function in positioning and sitting? So majority of the special children, they'll be having the sitting in the classrooms or home environment. So how we are going to handle the positioning? How far it is important to facilitate? So majority it will be like a function, means it is the activities of daily living. It will be supporting activities of daily living. For ADL, this is very supportive. So that's the reason we have taken up how to facilitate the gross motor function for cerebral palsy. So everything is a movement is the key for gross motor function. So how we are going to facilitate? So all the five senses, if we are utilizing in a proper way, we can facilitate the gross motor functions. Whether it is a hearing or a taste, smell, even with the smell or touch. So five senses is more than enough to facilitate the gross motor skills. So as per the ICF model, how we are going to improvise the functions. Once if suppose I'll explain what is ICF, International Classification and Functioning. Before we call it as a impairment, disability, handicap, right? So this is the impairment. Now it is rephrased as a ICF model. International Classification Functioning means if there is any disease or disorder, that means if there is impairment in the any structure. Structure means it is like a anatomical. Anatomically, it's whether it is a bone or muscle. We call it as an anatomical problem. Is a structure. If there is a structure is affected, that will limit the activity. If there is a limitation in the activity, it is unable to execute any task, then there will be he is unable to participate in the life situation. For example, suppose any spinal cord injury, someone text in the chat box, quadriplegia. They asked about the spastic quadriplegia. Suppose if I am giving it is a damage to the brain. It is a wheelchair bound. So I am providing a motorized wheelchair or with a joystick. Totally, it's like a motorized operated wheelchair if I am giving. That environment if I am creating, So what is the contextual factors? Environmental, personal factors. If he is unable to go to school with someone is assistant or physical assistant they are doing means, if he is unable to go to school, that is we call it as a limitation in the participation. If any spinal cord injury or any other injuries or any other physical problems, if he doesn't have a accessible environment, there will be a limitation. He cannot go to park, he cannot go to work environment. So then only we say, so first if there is any physiological or anatomical issue is there, then there will be a limitation in the activities. If there is a limitation in activity which leads to the, it will affect the participation. So for that, this environment, how we are going to create the environment for the children with developmental disabilities. So since the topic is position and sitting, so for a children with any profound cases or severe cases, the environment we are going to create the adaptations. We are going to create the adaptation in the class environment and home environment. Majority of the time, the children will be seated at the home or in the classroom. So how we are going to position? The personal factors like a dwarfism or age, gender, this all comes in the personal factor. So based on the ICF model, our goal is to make them as a effective participation. How for this positioning will facilitate them to involve the classroom, involve in the play, involve in the park or any other recreation, any activities, how you are going to facilitate. That is the one. So that function means physiological. Whether it is urination, whatever the breathing, everything comes under physiological, including psychological also, the emotions. So everything comes under body function. Structure means anatomical. Whether it is a limb, upper limb is affected or lower limb or any organs or any other components which is involved, we call it as a structure. The activity means unable to execute the task or any action by an individual, that is the activity. Participation means involving in the life situation. So whatever the environment I said, so that the environment we have to create. This is the terms used in international classification and functioning model. So what are the things we should remember? Some points we should remember while handling the children with cerebral palsy. Never encourage the child to pull. Most of the parents, they will be while getting up from the floor by holding the bar. So windows also, all those windows bar and all, they'll be doing the pull to sit. So never encourage for any spastic CPs and all. We don't encourage the pull. If you are doing the same pull to sit or pull to stand, you are doing harm for the child. That means you are strengthening the spastic group of muscles. You are strengthening. You are strengthening the muscles against spasticity. The tightness will be increasing. So for that, we should avoid all this pull. If you are training with push to sit, push to stand means that means you are making the child independent. You are reducing the tightness. So never encourage pull to sit. Then for certain things, all the times and all, they'll be doing the bridging, so holding on axilla, that back and all. Most of the parents, they'll be holding on the back, a side mobility. This and all, this is not advisable. Why? Because if you are training the child to make them independent standing and all those walking, all the postures, that alignment, if you are making them to better alignment with a proper support. Initially with support you try, later on you go for without support. That is a permanent. How long we are supporting, that will ease the child to make a dependent. So for that, so never try to do any abnormal stretching, all those movements. If there is any tightness, with proper instruction by the therapist or any other people, just think qualified people, you can go for the stretching. So if you are doing any all those movements with the proper appropriate knowledge, you can apply the stretching. Then if your child is sitting on the chair or at home and all, any CP chair or corner chair, whatever the assisted device, seating device you are giving, most of the times they'll be giving a So shawl or a towel, mostly they'll tie on the chest wall to prevent the stoop posture. Mostly the child goes for a stoop posture, right? So the trunk is leaned forward to prevent the fall or to maintain the gravity. Usually that is the alignment. To prevent the fall, they will be tying. That is not at all advisable. You are limiting the chest wall expansion movements. That means you never encourage where to tie is important to prevent the fall or a stoop posture around the shoulders. I'll show some slides, then you'll get some idea. These are all the points while handling the children with cerebral palsy. Never encourage pull to sit. Push is the weight bearing that will make the child independent. So pelvic bridging means the excessive pelvic bridging we are not supposed to do. Holding on axilla, holding on back, improper stretching. These are the points we should remember while handling the children with cerebral palsy. So, what is the importance of position? What are all the ways it will help? What is the benefits? First one is the enhancing motor skills. So how does it have the indirect effect? Suppose if I am giving any proper chair, most of the children's profound cases, when we ask the parents, they'll say this, the majority of the time the child will be lying on the floor, looking on the wall ceiling. The child look at the wall ceiling, the child never get the stimulation, that environmental stimulation we are not creating. Suppose the child, if I am maintaining in a proper adaptive chairs or any assisted device, if I am providing, definitely the child will get the eye to eye contact, maintaining. So there are many examples I can quote. So around 8 to 10 years of age, the child was lying on the floor. So we gave only the wheelchair, not with the appropriate, even not appropriate postural supporting device. Even a small wheelchair we gave. We gave the instruction for the grandparents. So they made him sit for just for half an hour, the chair, for daily for almost for 3 months. After 90 days, we used to go for the test check report. Then they gave the feedback like after 8 to 9 years of age, the child started holding the neck for few seconds and waving the hands. Child started communication. How does it possible? Means usually the child got the exposure of the environment. So if I look at the sustainability, if I keep on training the child with a lift your head means the child doesn't show any much interest on it. So if we give any, the child usually I said not in the home. I asked them to, I just gave instruction for the grandparents, just give her bath and just make her sit on the veranda. So what happened after 3 months, the child started holding the neck and raising the upper extremity. Child started communicating, saying hi, bye bye. So all those things, the child started communicating. How it is possible means a simple wheelchair, not even a postural support device. A simple wheelchair, what just to make the trunk erect. Look at the environment that stimulates the child. The child started exploring the environment. Friends, whomever crossing on the while playing, now they used to say hi. So almost the child started communication skills, social skills, gross motor skills. So almost upper extremity is like a fine motor also is improving by showing by waving the hands and all those things. So all the skills we are developing through the simple wheelchair itself. So how that much influence is there by the proper postural supporting device. And if you are maintaining a trunk in a erect posture, that will improve the activities of daily living, like brushing, eating, or writing. So all the limbs, whether it is the upper limb or lower limb, it follows the trunk. So the limb will be following the trunk movements. So trunk is the key point. You are aware the trunk is the key. If you are stabilizing the trunk in a better manner, the child's the writing skills will be improved. That attention, Mostly we suggest for the cerebral palsy, the postural deficit children only. But even with the attention deficit, children also now they are using for a CP chair. What is the reason? Just to make them like a sitting tolerance is improved after habituation. So even though it is the behavior issues, just to make them in a proper alignment and all, you are giving a holistic manner. We are providing the child improving the sitting tolerance. So if I'm stabilizing the trunk, it will improve the upper extremity functions, overhead activities, reach activities, all those things, whether it is eating or dressing, okay, having food or everything and all that ADL, whole ADL, basic ADL will improve on its own if you are providing a better trunk control. Third point is that to improve the joint range of motion. Definitely, cerebral palsy children they will be having the limitations and restriction in the joint range. If I am maintaining, so if suppose a crippled child lying for a 16 hours, 17 hours on the floor. No. Actually, someone is showing the PPT is not moving. I am explaining the same PPT only. I did not go to the next one. So someone is sharing in the chat box. PPT is not moving. I am explaining this PPT only. So that avoid fatigue. They will not feel tiredness. If I am providing a inappropriate position, it leads to the secondary deformities. The parents might be think the child is very comfortable in sofa. You think a child is very comfortable in sofa, but still you are giving a spinal deformity. The spine is going for whether it is a left away curvature or lateral curvature. The chances are there. In case of you are sitting in, if you are sitting in a hard firm surfaces, that trunk will be the child started maintaining using the muscles, trunk muscles. So avoid fatigue. So and again contractures and deformities, the secondary problems we can prevent. So what is the principle behind the positioning? First one is stability. Look into the stability. Second one is alignment. And symmetry. Symmetry means the shoulder should be in the level. Hip should be in the level. We call it as symmetrical. Third one is elongation. Sit straight. That elongation is the key. Make them as a comfort. Position of the therapist as well as mother or the parents also is very important to avoid the back pain. If I am carrying the child for a many hours for here and there for a rehab center or early intervention centers, definitely the mothers or the father they may develop the low back pain. So for this position of the therapist, how to carry, how to lift the child. So we should know, we should teach the proper position of the therapist or mother while giving intervention. The first one is stability, alignment, elongation of the back of the neck. Fourth one is comfort. Fifth one is position of the therapist. So this is the symmetrical I said. The ears should be in the symmetrical, shoulder level, thorax, the hip and the thigh position, foot position. All the 5 steps we should follow in the backward. If you are looking to the back positions, it should be in the same. The eye should be in the level. Neck and head position, shoulder height, thorax. Thorax means the chest level. Hip, look into the hip and the thigh position. Fifth one is foot. Foot is very important. Majority of the spastic cases, there will be a problem in the ankle. So postural assessment, when you check into the alignment, if you are looking into the alignment, look at the back view. This is the side view. Side view. In side view also the same, the eye level, same position of the shoulder, fine. Then for knee joints, if you are looking at the knee joint, where it is a going backwards or a full forward, that is the knee position is important in side view. Just remember that a 90-90-90 principle is more than enough to make in a appropriate position. Some people, they asked someone, they posted in the chat box. They asked me, sir, how do I sit at the profound cases? Still, that doesn't have the neck control. The child or anything doesn't have the neck control or trunk control. How do I make them maintain the 90-90? Suppose the recline position, instead of sitting in the straight, if I'm making a recline, the same 90-90 I can maintain the hip joint, even though the child doesn't have a neck control or trunk control. The chair should be inverted like this, semi-reclined. Instead of straight, you make it in an inclined position, but even knee also it has to be 90 degrees. You can prevent the secondary complication like a spinal deformities. You can prevent the secondary complications like a scoliosis or spinal deformities if you are aligned in a proper manner. So these are the basics, certain corner chair. Then for beanbag, for severe cases, we are advised only for feeding purpose. We'll be encouraging just for feed, like a beanbag we positions. Certain standing mobile stander is there, prone stander. So not only with the function, even with the autonomic nervous system from the ANS, autonomic nervous system function means like a bladder control. Then to prevent the osteoporosis. Osteoporosis is the weakness of the bone structures. To strengthen the bone, they have to weight bear. So we encourage the standing frames and all, not for the function. That will improvise the bones also, that to prevent the osteoporosis. Even to make them after standing this one, they said sir, bladder control has improved. So such ways that autonomic nervous system function also improves by the effective in the standing frames. So mobile standard, prone standard, supine standard depends on the child's alignment. We choose which one is the appropriate. This is advisable for classroom environment or even for mobility. This is a, you can transfer also. This is a mobile one. In classroom situation, the same. You just keep remember the 90-90 principle, and instead of tying the shawl or towel on the chest wall, you keep remember, just remember the shoulder you have to tie. Shoulder it should be in the retraction, then the trunk will be in the erect posture. I said about the elongation of the spine. If you elongate the spine, your upper extremity will be improvised. So just remember, if there is a head turns and all, head support is there, knee, ankle, everything should be 90-90 principles. In case of severe cases, you go for the tilted position, semi-reclined, reclined position, semi-reclined positions you have to opt for the severe cases. So in case the child has any wheelchair, for a better inclusive setup for some children have a level 1 or level 2. I'll show the levels of the cerebral palsy. So in this, we should have a wheelchair accessible classroom tables also we should have. Then only they can have the access for the better ADL or teaching strategies, whatever you are applying. You should have such a easy way to access the writing table or any other table or table job work or anything and all. It should be in this manner is advisable for wheelchair users in classroom. Instead of cutout, they will be using the cutout, but it should not restrict that footrest of the wheelchair and everything. It should not get stuck on the tables. What we have the cutout table, but this is the advisable. So what is the reason? The scientific reason to have a proper position. If suppose if I'm prefers the W sitting, stoop sitting, or any side sitting, just leaning on one side, this abnormal brain pathways of that damaged brain, repeatedly you are stimulating. You are repeatedly doing the same wrong posture. Then the channels get regularized. Once the channel is regularized, then it is we call it as a deformity. So that is the reason you are repeatedly you are stimulating the wrong pathways. You are creating. That we have to analyze the alignment in lying, sitting, and standing. The three is more than enough. How the child is lying, how the child is sitting, how the child is standing. If you look into the alignment, then it is easily you can overcome the majority of the gross motor functions. You can facilitate. There are certain things, there are the scientific reason they have proved. There are certain studies by proper appropriate seating position, it promotes the upper extremity functions. Then if you are proper seating, like a seating AF pose, orthotic devices, they're using in here right now, same the 1990, that cutout table, the hip belt, the footrest, all those things we are providing, that also will improve the upper extremity functions. So there are evidence support for the children's safety. The proper postural supporting device will improve the ADL activities. What is the facilitation? The definition of facilitation means making the things easier. Child is feeling difficult in moving or sitting and all. You are giving the easiest way, making the easier improvement of something. You don't expect someone asked that breathing will cure. So breathing is like a supporting mechanism only for respiratory function. Talk about CP is a different, totally is different with the motor disorders. Will affect the posture and abnormal muscle tone. So how you are going to facilitate the easier way based on the smart codes. There are 5 levels. Depends on the levels only we can treat. The first level is the child or adult is able to walk without any difficulty, without limitation. But difficulty in climbing stairs with any carrying bags, difficulty in climbing stairs. That is the level 1. Level 2 is the 10 steps the child is able to walk. Again, they may need support of the rail or some other furnitures or wall support. Then we call it as a walks with a limitation. That is the level 2. Level 3 is the child is able to walk with a walker or crutches, any other hand-held mobility device. That is the level 3. The mobility child uses with hand-held devices, walker or walker or crutches. So that means the first 1 to 3, little bit that thing improvement, the prognosis will be better. The first 1 to 3. Again 4 and 5, the postural correction is very, very important for level 4 and 5. Why? Because they will be
Sir, are you there? Sir, we can't hear you.
audible now.
Now we can say, yes, sir. Yes, sir.
So level 4 means walking with the child will be able to propel the wheelchair on their own. Level 5 is total wheelchair bound. Totally the child is a wheelchair bound. The physical assistance, attender or parents, they'll be moving this, propelling the wheelchair. So that means Level 1 to 3, so whether it is a normal exercise or mobility, is not affected. But in 4 and 5, the positioning and seating device is very, very important. So what is the majority of the major life skill activities only we have to focus for severe cases? For multiple is there cerebral palsy with associated problems, severe intellectual disabilities. Then you have to focus on the major life skills. So what is the purpose means if I am doing all this positional, it support the parents in toileting, and then in that changing the dress, while wearing the dress, our positioning that support all those exercise and all those postural supporting device will make the easier to give them a bath, or it will be easy for the parents to better for washing the for after toileting. So that supports the parents by proper supporting devices. It will prevent the pressure source. There are many areas we can say. Then modify the classrooms. Why? Because if you are giving a postural device, so their complaints will be
full screen
uh, so because of the difficulty in the posture, child is unable to place in the school. So if you are giving a proper advice, normal environment, their IQ will be normal. Only the motor is impaired. The child is unable to access the normal schools or all this environment, mainstream, then it
இந்த ரெஸ்பான்சிபிள் போட்டுட்டாங்க
leads to the.
பேமெண்ட் பண்ற டீடைல்ஸ்க்கு வேணும்னு கேக்குறாங்க.
So for that, we should then create a better environment in the classroom. Utilize all the alternative augmentative communication devices that is called as assistive technology. So the three areas, keep remember, one is life activities, basic ADL activities, all those things, major life activities we are teach. Second one, modify the classrooms and use the proper alternative augmentative communication device, that is we call it as assistive technology. The first treatment rooms, the posture starts with if there is any brain damage, high risk infant, you found the child is having a premature or low birth weight, then first the treatment room starts from the hammock. So if the treatment room, scientifically proven, there are two journals is there. If you go through, if you are maintaining the neck in a midline, the child, someone said it's a 80 NR. How far it 80 NR will reduce on its own if you are maintaining the neck in the midline. So if there is any delay in neural maturation, premature or low birth weight, there will be a delay in neural maturation. For those children, if you are providing this hammock in a right way, that will improve the, reduce the abnormal reflex. The pathological reflex will inhibit
அவங்க பேமெண்ட் எல்லாம் அட்டன் பண்றாங்க
or that facilitate a rolling. So for those all those things and all, hammock will reduce the disorganized infant behavior, will facilitate the motor skills like a rolling, upper extremity, the kicking movements, all those things and all. The treatment room starts from the child gets the multi-sensory stimulation. I said in the beginning of the slide, the movements the child start, if there is any rattle is there, sound, so the nipple or whatever this thing, the child started with the taste, auditory stimulation, hearing or touch. Mother's saree is the smell, the stimulation the child, all this multi-sensory stimulation the child gets the beginning stage itself, that infantile stage itself the child gets. That will give the better stimulations for facilitating. There are two areas is there. One is habilitation and rehabilitation. The habilitation is the one what we are doing. Child doesn't know how to roll, how to sit, how to walk. So that means you are teaching a new skills. It's called habilitation. Already I am aware. In between I got a seizure. Again I get back. That we call it as a rehabilitation. So this part, the habilitation part, the multisensory stimulations, it works better. for premature and low birth weight children. There are 5 dimensions we have to work on it. The first one is lying and rolling. Second one is sitting. Third one is crawling and kneeling. Fourth one is standing. Fifth one is walking, running, and jumping. How to ease. So that is a book called David Werner. So if you are having this community based, if I think if the child or adult is unable to reach the environment sector, majority of the home sector, how to transfer our knowledge to the parents. There are 2 areas how to improve is the neck control. This is the 2 developments we will be focusing. The child has to get up on their own. One is the supine development, is their prone development. The first dimensions based on the neck control. The child is able to sit without support within the 4 years of age. Within 4 years of age, the child is able to sit, then the child will be able to walk without any assisted devices. What does it indicate? That is the indication the child has a better trunk control. The child may be 100%, the child will be able to walk without any assisted devices. So they have done this study with the 300 sample. So that means our focus should be within a 4 years, the child should be able to sit. This is applicable only for the cerebral palsy. So once the trunk is better, the child will be able to walk. So that means that the first initial step to begin with the neck control. Once the neck control is improved, then automatically sitting also it will be vice versa. It has a so one is the prone development by play method, like father or mother or someone should they should reach the nose, head, touch my nose or touch my head. So all those things and all, if you are facilitating, reach, that is the permanent one. That stimulation, that involvement with the peer groups or siblings. If you are involving the siblings by play methods, if you are facilitating, that is the easiest method to improve the neck control. Or better, the rattle movements, or how the recline position, the supine development, how to, instead of pulling, how to push, how you are going to facilitate, and lying to sitting. The 2 developments, if you are facilitating with one, that top one is the 2 photos for a prone development, the bottom one 2 photos for the supine development. This is a supine prone development is a basic things we have to teach for lying to sitting. Again, for a better head control, see the way they have, the child has to be, the trunk is stabilized, child has to be looked with the eye level. Second photos, it's like with anything like a rolling, we have to initiate siblings. The prone wedge, the third image is like a prone wedge, the upper extremity, reach, or any play methods, or just give some activities. Then it will be easy for the upper trunk movements we can facilitate by the prone wedge. Keep some pillows in a slanted position also we can improvise. So that means you are stabilizing the whole body. Only you are avoiding all those trick movements. Majority of the problems comes by the, there is any inabilities, they will be utilizing with the trunk trick movements they will be doing. That is the major secondary problems they will be facing. So to avoid that one, for neck control, an important dimension is sitting. Crossing the midline like a toys, shifting the toys from right to left, left to right. Then they play with the bilateral hand coordination with the back support. Anything. Most of the times what we used to do, that parents and all, they don't allow the child to wear the dress. They don't allow the child to wear the dress with the extremities. Usually they'll be, the child don't lift the hand. So if you are giving for half an hour, that it takes 30 minutes or 40 minutes, doesn't matter. Later on by practice, there may be a duration may reduce. So I think there may be decrease in the durations. By practice, it will be easy for them to lesser duration, they can complete the process. So that means that with support, with the corner of the walls, you can make them sit to facilitate the dressing skills. Initially, go with support, like an inverted stool or something, whatever is there, initially go with both hand supports. The child, that means you are making the child's comfort zone with on their own they are doing. If the parent or anyone is supporting, permanently the child will be dependent. To make them, first initially you are sitting on your own with both hand support. Then it's one hand support. The right hand support or left hand support gives them activities. Then child starts learning how to sit without support. So once the child started, then it will be easy for writing skills or any other ADL skills. So for those, we have to work more on the sitting. Then moving from one place to another. First step of locomotion is the crawling. So next to creeping. So first is the creeping, the child starts, right? So in this, you are raising the center of gravity, then the child starts moving from one place to another by crawling. So crawling, if once the child is able to crawl properly, then kneeling. So that means whatever we say, it is like a cephalocaudal approach. Head control should be there, then trunk control, then hip. What we say is by plastic chair or stool or whatever is available, go with the hip control. If hip is good, we can facilitate the motor skill. This all comes under gross motor functions. So starts from the neck control, trunk control, hip control. Hip control by using this with support. Initially train with support. Give some activities like a clip, any cloth, certain clips or something, any activities or painting, whichever suits for the environment, whichever the child's like, we can facilitate the hip control by doing the kneeling itself. We can work on the painting skills or any other activities you can perform in the kneeling. Then it's the fourth dimension is the standing. Standing is the one almost the child once the started able to stand without support. Is it audible now?
Yes, sir. Yes, sir.
Okay. Okay. Someone posted this down in the okay. So once the child or adult is able to stand with any individual standing, no need to teach walking. They'll be able to walk. So that means the fourth dimension we have to work on the standing. Support like a parallel bar or whatever this thing available, we have to go for the standing. Then it is a last dimension is walking, running and jumping. We have to teach the lower limb coordination exercise. Case of ataxia or imbalance gait and all, with support. If the parents or siblings and sit together with one hand support, with right hand support, they can walk. While coming, they will be using the left hand by using the orthosis. Just look into the images, you'll get the lower limb coordination, the stepping, the frequent fall. Child gets struck up with any small objects, also they complain the frequent fall. That falls we can improvise through the lower limb coordination exercise. Kicking football that supports with support of the chairs, that will facilitate them to climb stairs at one leg standing. So playing in the standing method that will facilitate the walking. Those who have a imbalanced, make it like a balanced board or any other writing pad to make them stand with the pillows. That will be easiest method to improve the balance in walking. So if you are able to achieve this all the 5 dimensions, then it will be the gross motor functions. It develops on its own. So what is the effects means? The effects of good posture. First one is you are normalizing the muscle tone. Increased tone you are going to reduce. Decreased tone you are going to normalize. In case of fluctuation, uncontrolled movements, that also you are stabilizing by the proper alignment. Skeletal alignment is better. So even the deformities, stable, giving a stable base. The child is very comfortable if you are maintaining a good posture. Pressure sore. If I am having abnormal postures in one area, one bony prominence is giving a more pressure, that leads to the pressure sore. Then maximise function. This is the major benefits of good alignment. If you are making a good alignment in the school environment or home environment, you are preventing or you are facilitating these are all the areas. Normalizing the tone, skeletal alignment, preventing the deformities, providing a stable base, relaxation. The child is very comfortable. Preventing pressure sore, maximizing the functions. Our goal, how to fix up the goal, whether it is the IEP or anything and all, you'll be having a goals, right? So quite similar, that should be the specific. The child, our goal should be very specific. The child is, usually the child may not have the neck control. The parents or any other thing, they'll be expecting when my child will be able to walk. So our goal should be on the neck control or rolling or sitting. So like that is a cephalocaudal approach. So head to toe should be there. That means you should be able to clearly explain the short-term goal. That is, we call it as a achievable. Second is measurable. Should be measured. The rolling twice, kneeling with support for 10 seconds should be a measurable. That measurable areas you have to go for it. Achievable. Once the neck control is not achieved, you have to go for neck control, not with the standing or last dimension. You should not go. That's why achievable, relevant. Go with the relevant. Your goal should be relevant. Timing is very important. How long I can work on it. Some children, if you are providing 24 hours, also you cannot show improvement, but you can maintain the condition. So our goal should be very specific, measurable, achievable. That means your goal should be SMART goal. So common mistakes already explained. This is the way I said by holding the back or axilla. So gross motor play is the effective participation. So giving like any activities, the one leg standings, any gross motor play skills, overhead activities, even indoor also. Make any adaptations. Make some adaptations with the children's play environment, the home environment, sitting with anything, any traditional play or any other based on your cultural environment. Just they have to involve in the play activities. So any traditional, whether it's a squatting or upper extremity coordinations or anything traditional methods, you can go for it. So actually my aim is like almost the gross motor function is if you are for cerebral palsy, if you are having the only 5 dimension, if you focus, that is the easiest way to improve in the classroom or home environment to prevent that many deformities. Overall motor function is improved by proper positioning is more than enough. So if you ask the parents what is the majority of the position the child's lie at home, then he will be able to solve many issues. So that prescription of suitable assisted devices, whether it is neck control is not there, we will prescribe the cornet. Trunk control is not there, we will prescribe a CP chair. So if the child doesn't have the hip control, we will refer to the prosthetic engineers for proper orthotic devices. For mobility, which device is important? So all the things, the prescription of orthoses or assisted devices, almost 2.5 billion people globally, they may require 1 or 2 assisted devices. The postural supporting devices that will ease the child for better inclusion. There are many things, all the AAC, alternative augmentative communication. The hand is there, it's upper lower limb coordination or upper limb uncoordinated movements is there. Head is having good control, they can have a head pointer. Only the whole body is paralyzed with the muscular dystrophy, but still the eyeball movements, they can use the AAC. So anything, the assisted devices, we have to incorporate with the intelligence, the cope up with the intelligence, the peer groups, they should have exposure with the environment for better inclusion. This is the areas, if you have any doubts related to the facilitating the gross motor functions, you can put up in the chat box. Someone is better way for ensuring safety.
So there is a question, what is the better way of ensuring safety while in seated position instead of strapping the child?
The question is not visible.
Can you hear me, sir?
Tell me, madam.
The question is, what is the better way of ensuring safety while in seated position instead of strapping the child?
Exactly. Yes. I said I'm semi-reclined position. I said now. Madam, my video is visible.
Yes, the last slide is there, sir, and we can see you also.
Let me share this. Okay. So now it is visible. The ensuring safety. Actually, majority of the usually parents what they'll do now. They'll be tying the I think a towel or shawl now in the corner chair. Usually it will get stuck on the neck. While sliding movements, while skidding from the corner chair or CP chairs, you should have adductors which adductor. Adductors means in between the thigh there should be adductor which instead of strapping. That the hip should not skate forward. Adductors ridge, and then for if you are elevating the knee little bit higher than the hip joint, then automatically you will be the slouch position. Slouch position means you will be skidding. The slouch position can be prevented if your knee is higher than the hip level. So automatically your pelvis, that is KM used to say, that is the hip bone, it will be seated properly instead of thigh. So how you are positioning the tumble form used to say, tumble form chairs. So prescribing that is the safest method. But even though if you are providing the shoulder strap, that will not do any harm for the child. You are doing with the chest wall. Chest wall means here, if you are tying on the chest strap, is you are restricting the chest wall movements. In the axilla, even with the axilla, soft paddings. Soft paddings means with the cushion or foam, you have to give in the axilla. That is the safe method. Any other queries?
Thank you, sir. No more queries. Please post your queries in the chat box. No more queries in the chat box, sir. Hope everyone are clear with your presentation. Sir, one more question. What is recline seating for CP? What is recline seating for? Okay. There is one more question, sir. What is recline seating for CP?
Is it visible, ma'am?
Yeah, fine. We can see, sir.
Okay. Actually, the child should be, in case of the recline, means this is the recline. This is the hip is 90 degrees, knee should be 90, ankle. This position, if they are maintaining, the child not required for the any assisted device like a neck control is not there. This we call it as a recline. The position for severe cases, profound cases, this is appropriate. So the SKM is properly seated. Will not have the spinal deformity. This we call it as a recline position. Is it clear, ma'am?
Yes, sir. Hope they have understood. The next question is, sir, CP child, can they take education normally like hearing impaired child?
Definitely, ma'am. If the intellectual is not impaired, the intellectual component is escaped. That's actually the cognitive area is escaped. Definitely, they can go for the normal education mainstream. Only the motor skills is impaired. You all use all the alternative like a joystick or any other tab. So only the writing skills or reach, coordination or any other motor only is impaired, but the cognitive area is escaped. Then it is 100% they can go with the accessible AAC device. They have to use all the AAC devices, whether it's a pedal mouse or adapted keyboard. There are many devices up to 7th, 8th standard itself. The syllabus, they have the curriculum in the normal streams with the alternative augmentative communication itself, they have the syllabus to learn from the system. How to express that? There are many methods to express that for writing skills. If I'm typing, like is means there, th means automatically right. So quite similar. Cognitive cog means automatically. If you're using the repeated words on its own, it will be typing. So all that AAC device they have to use.
One more question related to the same, sir. Actually, they are asking whether the cognitive development in CP child will be normal.
It depends on the brain damage. So every child, it's like associated problem is cognitive. Not all the children will have the cognitive impairment. There are many people with cerebral palsy, they have completed with a doctorate. Now this any higher studies they have done. It's not mandatory all the CP they should have a cognitive impairment. But
Hope he's
actually,
clear, sir.
the physical impairment will leads to cognitive. I'm saying, why? Because they usually they don't place in the normal schools. Again, ma'am. So how do you recommend supporting head brace to assist with positioning child with torticollis? No, torticollis is a congenital deformities of the sternocleidomastoid mastoid. So that is a child with any torticollis. You don't recommend. You go for the normal stretching. Chin tuck with stretching. If the active stretching, go for it. So all the upper trunk muscles like a trapezius, all those muscles, the accessory muscles you stretch with the active exercise. Then it's a passively you have to support. So it is a congenital deformities. We don't recommend. I think it's not advisable for a head brace.
One more question, sir. How much time interval is required for change of position in classroom?
Classroom every half an hour, maximum 20 minutes they can have. So any assisted devices, maximum 2 hours, minimum 2 hours they have to use it. Minimum 2 hours. Give interval. For changing the position, just everything is just like by holding the wheelchairs or lift for every half an hour once, just for 2 seconds enough. They have to do the tilting. That means if suppose in case of if I'm holding like this, if you stretch with the midline or right enough, every half an hour once, any crossing the midline activities if I'm giving, automatically the pressure sore, all those things you will not have if you keep on changing with every half an hour.
No more doubts in the chat box, sir. Please post your queries if it is there in the chat box. Hope they are clear, sir. Thank you. Thank you so much for your
Thank you
wonderful
so much.
presentation.
Yeah, thank you so much,
It
ma'am, for
was,
giving this opportunity.
it was
Thank
very
you all.
much.
Thank you all the participants. Thank you so much.
Thank you, sir. With this, we move on to the third session for today's CRE program. And for the third session, I feel happy to introduce the speaker, Mrs. S. Sindhuja Madam. She's a lecturer in physiotherapy in NIPMED. She holds a postgraduate degree in physiotherapy in neurology, and she has also done a post-graduation diploma in developmental therapy. She has wide experience as a developmental therapist handling with disability and neurodevelopmental therapy. Now she will be talking on the topic positioning for children with CP at home. Over to you, madam. So, good afternoon, all are not present here. So, am I audible? Okay, so good noon, everyone. So, I'm Sindhuja. I'm going to talk about positioning for cerebral palsy children at home. So, I will first share the screen. Let me know if you can't see it. So, my topic is about positioning for child with cerebral palsy children at home. So, the previous speakers they already explained you about what is cerebral palsy and what are all the things they have, therapies they are giving and positions, everything they have told you. So, only thing is, I'm going to repeat the same. All the introductions will be the same. I'll just summarize what are all the things uh, we have to say. So, can you first? Can you see the PPT? Can you see my sharing? It's not sharing. I'm seeing. I'm showing. Are you able to see the screen? Okay, so we'll start with what is cerebral palsy. So we all know, but still we need to be like recollecting what are all the things we studied already. So we'll start with cerebral palsy. So cerebral palsy, what is it? Actually, due to brain damage, there is irreversible brain damage. It is not a progressive disorder. It's going to be non-progressive disorder due to the brain damage. During it may be during birth or after birth, that is pre, peri, and postnatal. So I cannot tell you the exact cause, what is going to cause cerebral palsy. Yes, so it's going to be a non-progressive disorder which is going to affect the brain uh, during the initial phase of the brain birth. Okay, so that is going to be the definition. And we all know, being in this rehab profession, we have seen so many types of cerebral palsy. So first, I'll start with, there are so many types mixed. So first is going to be spastic cerebral palsy. So we have spastic type, flaccid type, mixed type. So we'll see about that. First is going to be spastic cerebral palsy. So in spastic cerebral, what is spasticity? Spasticity meaning the usual tone is going to be increased. It's going to abnormally, there will be an increased muscle tone is going to occur. So that is going to be spasticity, where there is upper motor neuron lesion because of brain damage. the tone of the muscle is going to be affected. So first is going to be spasticity. So this spasticity, they have different types. So some children, it depends upon the brain damage. What part of the motor cortex is going to be affected? According to that, it is going to show it on the body. Yes. So spasticity, we have spastic diplegia. Diplegia meaning di means two. So diplegic, automatically it's going to affect two limbs. Mainly, as far we have seen, two lower limbs, the two legs are going to be affected more than the upper limbs. Upper limbs, sometimes some children they will be mild affect will be there in upper limb, and some children they will be able to manage very well with both their upper limbs, both their hands. Only thing is they will have affected legs. So that is going to be diplegia. So coming to next is spastic hemiplegia. Hemiplegia, we know it, hemi meaning half. So half plegia, where the half of the body is going to be paralyzed. So this can be hemiplegia, can be seen in adults and also in children. So we are talking about cerebral palsy. So it's going to be like hemiplegia, or hemiparesis can also be there due to the brain damage. The part of which part of the brain damage it's going to be hemiplegia. Next, coming to the quadriplegia. Quadri meaning four. So four limbs are going to be affected. So that is spastic quadriplegia. Dyskinetic cerebral palsy. So in spasticity, we have one more thing called dyskinetic. Dyskinetic meaning dys meaning there is no proper what to say symmetry or movement. So that is this kinetic, there is no proper force that is given for the movement. So the movement is going to have a problem. So for example, in dyskinetic cerebral palsy, we are going to have dystonia, athetosis, chorea. So these are all some of the types where we can see involuntary movements. These children, they will have difficulty in controlling their movements. So this is dyskinetic cerebral palsy. It is going to come under spasticity. Even though the athetoid type, in that children, we can see fluctuating tones. They will be sometimes they will look so spastic, sometimes they will go for complete flaccid. We will be confused in which type they are. So mostly this athetoid type of cerebral palsy, they will have mixed type of muscle tone. Then coming to ataxic cerebral palsy. Ataxic cerebral palsy, mainly it will be due to cerebellum. We have brain parts. We have cerebrum, cerebellum, pons, and medulla oblongata. These are all the parts of the brain, right? So when the cortex cerebrum is going to be affected, mainly we have this cerebral palsy, right? So along with that, when there is damage is going to happen in cerebellum, we can see this ataxic cerebral palsy, where cerebellum is the main part for the balance, to maintain the balance and posture. So what happens when that part is going to be affected, excuse me, that part is going to be affected, they will have issues in maintaining their balance and posture. While walking, you can see they will walk like a drunkard's gait. Like when a person is drunken, how they will walk, that the same way they will be walking. That is ataxic cerebral palsy. So then coming to the mixed cerebral palsy. So mixed cerebral palsy, as I told you, in case of athetoid CP, you can see how they are they will be changing their tones, like spasticity and flaccidity, everything will be mixed. Sometimes um, if you ask them to do some work, what happens, they'll go for spasticity. If they are relaxing, what happens, all their tone will become very loose. So this is how the mixed cerebral palsy will be. Then coming on to the topic, so speaking about positioning of the child with cerebral palsy at home. So for a position, what is position actually? Position meaning when you are able to hold your body according to the um, situation or the environment. For example, we can say like you people are sitting now, maybe lying, sitting, standing. These are all some of the positions. So for that position, what are all the things we need in a body? First thing is posture. Yes, proper posture should be there. What is a posture? Posture is going to be, it is the attitude assumed by the body, either when the body is stationary or moving. That is posture. So, for example, now I'm sitting. So, I'm just maintaining my posture straight. So, I'm just sitting in one posture. This is one posture. Yes. So, what happens for this postural control? What makes you to control these postures? There are some systems which is going to work to control all these postures. So those systems are like musculoskeletal and neuronal systems. So these two systems are going to work together. They are going to interact with each other, and they are going to control this posture. That is called postural control. Um, for this posture to be maintained, what we need? We need normal muscle with proper muscle tension and the postural tone. These are essential for dynamic postural control, which in turn it's going to be a prerequisite for movement control also. So for movement to happen, we need a proper position, a posture. Should we need posture? For that posture, what we need muscles, proper muscle and tone. These are all very important. So without a proper muscle or tone, you cannot maintain the posture, right? For example, just imagine a skeleton, just a skeleton which with only bones. So, will you be able to make the skeletons stand erect or sit properly? No, we cannot make them to do it. Why? Because we don't have any other structures. So, only the bones are there. So, what we need structures to make the skeleton to maintain the posture. So, what are the structures? We have muscles, mainly muscles, ligaments, tendons, capsule for the joints. So, all these structures we need. Along with that, we need the organs to work. So all these things collectively, which is making you a human being, is making giving you a structure. So for now, I'm talking about the muscle, right? So the normal skeleton, we need the muscle to work. Muscle, and that muscle, it should have a proper tone. Every muscle will have a tone. So muscle tension will be there. When you see, normally, even if when you're relaxing, your muscle will have a natural tension inside it. So that is called muscle tone. So that tone is keeping your body in a proper position. So whether you're lying, sitting, or standing, whatever position you are, this tone is going to make you keep your body in a proper position according to the environment. So this is what I was telling you. So what are all the things we need is first tone. Yes, tone of the muscle. So I told you about the muscle. Muscle, just like that, we don't need the muscle. We need the muscle with proper tension. So every muscle will have a proper natural tension in it. So that tone have to be maintained. If there is any issue in the brain, what is going to happen? This is going to create a tonal issue. For example, cerebral palsy, what is happening there? There is a damage happening to the brain. Immediately, what is happening? It is showing in the body through the muscle tone and the posture, right? So, due to that tone, when the tone is not proper, what is happening? The posture is not able to be maintained. The child or any adult, when the tone is not proper, for example, when there is too much tone, that is, increased tone is going to be spasticity, decreased tone is going to be flaccidity. So when the just right tone is not there, when it is going to be increased, what happens? It's going to be too tight. The spasticity, it's going to be too tight, which is going to make the joints and bones in a posture in a very different way if it's not being corrected. In case of flaccidity, the muscle is going to be too loose. So what happens? They won't be able to keep their position upright. Just like that, they will be just dropping their body down. So we need a proper tone, first thing. If that tone is not proper, what happens due to tonal issues? What is going to happen? Posture is going to be affected. Okay, this posture, when it is going to be affected, for example, a spastic child, when he's going to be Can you hear me now? So actually, we had an issue here. We had a power cut. So just bear with us for 2 minutes. So I think you can hear me, no? Can you hear me? Yes. Okay. So we'll go back to the session. So I was talking about the tone. When the tone is not proper, it's not going to maintain the posture. இல்ல, இங்க correct ஆ இருக்கு போல. Here it's fine. So you're able to see the slide? Just a minute, ma'am. I'll try. Yes, connected. Oh, sure. I think now you should be able to see the slide. Right, no? I think they are. Okay, I'll start the session now. Okay, I'm coming back to the session. So tone, when the tone is not right, you're not going to get proper posture. And that posture, what is posture? I told you, which is going to the alignment of the body. For example, your head is going to be aligned with your trunk and your limbs. So you are just like the midline is right. Your right and left is going to be symmetrical, right? I think now it's being connected. Close பண்ணிக்கலாமா? I think now we will be able to see the slide, isn't it? So I think you are able to see the slides, right? So we can start again. So I was talking about tone posture and the posture affecting the alignment of the body and stability issues it encountered. Okay, so as I told you, we have the right and left, right? So when you see both are equally distributed and it is in symmetry. So one is not placed down and one is not up. Yes, we are in symmetry. So that symmetry has to be maintained. So when the tone, there is a problem in tone, it's going to affect the posture. And that posture, when it is going to be abnormal, so that is going to affect the movement. So process. So when tone is being affected, when that cerebral palsy child maybe சாட் இப்பதான் வருது எனக்கு கொஞ்சம் கொஞ்சமா.
மேம் ஆக்சுவலி நான் இதை போட்டுட்டேன் கேட்க முடியாது.
நீங்க இப்படி பேசுறப்பயே கேன் யூ ஹியர் மீன்னு கேளுங்களேன். அவங்க
Okay.
சாட்ல போடுவாங்க எஸ்.
Okay, now people, can you hear me? Sorry for the interruptions. See, there are so many, like, the climate is not good and the current is power is just fluctuating here. That's why we have a problem here. So I think now it's connected. So can you hear my voice and can you see the slides?
Yes. Can I proceed with the கேட்போமா?
Can I proceed now? Oh, okay. Okay. Actually, I was talking, but I didn't see that the network had an issue. So first, I think I have to repeat it again. Tone, posture, and movement, right? Tone, posture, and movement. It has to be important for the positioning. I'll just make it crisp and clear. Okay, why positioning is important? So, being a cerebral palsy child, we have the tonal issues, the posture issues is going to come. So, to these proper positioning, what is going to do? It's going to prevent the further secondary contractures and deformities, which is going to create. That can be avoided. And proper positioning, it's going to help the child to interact with their surrounding and with the other people, and it is also going to help restrict their involuntary movements. Involuntary movements, in the sense I told you, in case of athetoid cerebral palsy, what happens? They will have so much of involuntary movements. That can also be minimized by positioning in a correct, proper way. So they also provide opportunities for the child to experience various postures. Okay, so correct positioning is very important. So these are all the some of the what to say important points that we have to consider while positioning a child. So from now on, you will see only the pictures so that I can explain you. Um, Now you are able to see now. Sarita?
Why positioning is important?
Yes, yes, okay. So here you see a picture of child. Yes. So one child is sitting with the hands in front, and child is sitting in W sitting. We call it as W sitting. And what happens? One hand is flexed, and one hand he is trying to support himself. So in this kind of positions, what happen? They have very less chance of exploring their environment. So if you give toys also, what they do, they will not be able to explore it. Why? Because they are trying to hold the position and they are trying to support their body with their hands. So what can be done? Positioning. If you give the proper position for them, what happens automatically? All these problems can be solved. So what is the correct position? When there is a proper stability, better stability, a child is going to have, which means when you place them in a correct position, they will be more stable, that they will not fall off or they will not be uncomfortable. They will be very comfortable. Stability is important. They will be able to move easily. They will be able to move their hands and legs easily. So that is how you can check. Their head has to be straight, not tilted. Like some children, or they will have a tendency to move their head towards left or right according to the what's it, muscle contractions, right? The body have to be straight, not bent, bowed, or twisted. The trunk have to be straight. This is the main principles you have to follow to maintain a position. So body weight is borne equally on both sides of the body. When you position a child in such a way that you have to check for their head, it has to be straight, and the trunk have to be upright, and the weight which is going to be giving on the body, it has to be equal. It should not go on one side. It has to be equally distributed throughout their body. So these are all the some of the what checklist you have to follow during positioning. Coming to the strategy for positioning. So what are all the things we have? What are all the strategies we have for positioning? So coming on to, like, usually a baby is born, a new baby is completely carried by the mother. Okay, so when it comes to cerebral palsy child, also for few months or for few years, they will be able to carry by themselves, but it is difficult to carry all the time. When they are getting heavy, when the child is increasing the age, it is very difficult for them to carry. So what can be done? So the proper position have to be done. So we have some strategies. What are they? Holding the child, using a body to position the child. Okay, so usually we do this in our therapy. So when we are doing the therapy, what we do, we usually do the therapy along with, we help the child to hold the position with our body. The same way you can use the strategy. Then coming to using standard everyday furniture, like at home, we don't need, like, we cannot afford, many people, they cannot afford so different fancy furnitures for keeping the baby in such a position. So what can be done? We can use standard everyday furniture. Whatever you have at home, you can use those furnitures, and we can make the child to position in a proper way. Special furnitures we have, wheelchairs we have a CP chair or a corner chair we have to make them to sit upright. Prone wedges can be used. Standing frames. These are all some of the materials or furnitures usually used for positioning. So main goal of the position, as I told you before, main goal of the position is going to be to normalize the tone, or to decrease the hypertonicity, to decrease the spasticity, or to facilitate the muscles which is going to be flaccid, to maintain skeletal alignment. As I told you repeatedly, you can hear the tone, posture, and the movement, right? We have to normalize the tone or decrease the tone, or we have to keep the what to say. Main goal is to make the alignment proper. The body should be properly aligned. To prevent the deformities, further contractures, we need proper positioning. So provides better stability. When you position in a proper way, that child will have a better stability. So they will be able to control their body in such a way that they can maintain it stably. Promoting relaxation. So, for example, if you are in a very good position, your joints, your muscles, definitely they are not going to work too much. If you are in a proper position, these the muscles, joints cannot, no need to work too much. So what are their work? Minimal work is enough for keeping their body in correct position. So if the position is not maintained, if the body is going to be in an abnormal way, the child is keeping their body, what happens? There is abnormal muscle work will be happening in one side, and other side there will no muscle work happening. So what happen when too much of muscle work is happening? That side, the muscle will start becoming so tight, and slowly what happens, the alignment will go, the posture will not be maintained. Slowly the spine will go for curvatures, abnormal curvatures. So these are all can be avoided with proper positioning. Then at last, decreasing the fatigue. So in our Indian culture, usually mother, father, parents usually carries the child. Okay. So when it comes to cerebral palsy children, when there is a musculoskeletal disorders or neuromuscular disorders, it's going to be difficult after few years of that child birth, right? So what happens automatically, that it is very difficult for them to manage that abnormal postures, and to proper positioning, which helps to reduce all these postures and involuntary movements. So these are all some of the points what I'm telling to maintain the position. So how important the position is. So here I start. So here you can see a child In one side, you can see a child is carried, a child who is more spastic, he has been carried. So what you can see is the child is going backward, is going more spastic. So his head is going for extension, and his back and his legs, they are going for complete extension. So this is not the correct way. And you can see one mother is carrying their baby in such a way that which is going to increase their spasticity. Okay, so how can we reduce it? There are some correct ways. So you can see here that there are two correct ways they have given. So where you can see the mother is carrying the baby, this is this position 9A, where you can see is this is Indian way of carrying a baby, right? This is the very best position for a spastic child, where you can reduce the tone. If you can see, his hip is being flexed and his hands are being flexed, and he's able to look at his mother. Yes, clear. So what happens because of this? The that complete extension can be reduced through this position. And the other way is like this: the mother is supporting the baby's trunk with her body. As I told you before, with your body you can position the baby in a correct way. That is how they are doing here. So the baby's trunk and head is maintained by the mother's body, and she is trying to flex the hip so that they don't go for complete extension and they don't go for complete spasticity. So here also you can see how to reduce the first picture I showed you, which was the incorrect way of carrying the baby, which can be solved by positioning in such a way. So these are all some of the correct positions where you can see reduce the spasticity of the baby, and also they will have a chance to explore. So if you see this picture, you can see the child's shoulders is free now, his hands are free, his legs are no more like too much tight, it is being relaxed. So now if you give a object, the baby will be able to explore it. So this is one way of. So here, this is one way of carrying. Usually, what we do, um, practically speaking, so if you want to take the baby from room to bathroom, okay. So your goal is you want to give a bath to the child. Yes. So you are taking the baby from room to bathroom. So not one day, every day you are going to do this. From one place to another, you are going to carry the baby. So if you're going to carry them in a improper way, that is also going to induce improper position, which is going to lead to some secondaries. Like I told you, increasing spasticity and increasing the deformity and contractures. So this is one way of incorrect way of carrying. So what is happening here? The child is completely passive, where he's not, his hands and legs, everything is closed, and he's not having any chance of communicating with his mother also, and also with others. The eye contact is not there, and he's having very less chance of exploring the objects. And while you're doing this, what happens? This is going to completely lead to asymmetry, where the alignment is not going to work. The posture will have definite postural misalignments are going to happen. So we have different types in spasticity. Severe spastic children, one type, the child will go for complete extension. In another type, the child might go for complete flexion. It depends upon the muscle work, how they are, the muscle is, which muscle is working. So first I showed you the child which was complete in the extension. Okay, so for that, how to carry, I just explained you. Here we can see the child. For example, if the child is going to be completely spastic with complete flexed position, so here are some good positions where you can reduce that complete flex posture. Here what they are doing, They are just extending their legs and hands, and their trunk is being straightened. So this position helps them to reduce that improper position. So this is one way to reduce the spasticity. And in case of flaccid, like low tone cerebral palsy child, they'll be completely flaccid, right? So this is also one of the good positions for them, so that they will be able to look around the environment. If you see, the mother is with her body, she is maintaining the baby's trunk upright, and she's holding all the legs and limbs together, so that it's not, the loose joints is not going to give you any damage. So here they are providing full body support. They are keeping in flex posture. So mainly they are avoiding wide range of hip abduction. When the hip is going to be abducted abnormally, what is going to happen? There are chances of hip joint just dislocating from its position. So that dislocation, um, if that dislocation is going to happen, here the growth will be hampered. So this is another way of carrying the child in prone position, where you can see the child is able to lift his head and keeping his arms to explore. So he will be able to look around, right? These are all some of the correct positions you can use. Okay, now all these things we are talking about when the child is not having any abnormal movements or positions, right? So when there is a spastic, when there is a flaccid, what are all the positions you can follow? How can be carried, and what are all the positions you can follow? I told you. Now we'll just see here. See, if going for the bigger child, already he is in complete spastic, he is severe. So what are all the things you can use at home? So here you can see the child is lying on the mat with scissoring gait. With scissoring gait. Yes. So here they have given some like materials like T positioning roll. This is called T positioning roll, and a neck cushion has been given. Yes. So practically we cannot buy every material, right? So what can be done? So here they are showing how to position the baby. So what can be done? We have pillows at home. Yes, we have pillows and wedges, what prone wedges we have. So with that itself, we can position the baby in such a way so that we can reduce their abnormal movements and reflexes. So here you can see asymmetrical postures of an older child. Okay, so when they are already in severe spasticity, what is happening? They will not have proper symmetry. The symmetrical body is going to be asymmetrical. So what can be done? So here at the right hand side, you can see they are using a T positioning roll, firm head pillow, and the back support they are giving. So instead of this, what can be done? Okay, so you don't have a roller. So what can be done? Pillows can be used. Towel rolls or bed sheets can be rolled into in such a way so that you can place them in between the legs or the head. And for the side, what can be done? We can use wall or any other furniture we have. Sofas at the back side of the sofa or wall can be used to make them lie on the side. Here you can see the picture 29. So where the child is sitting, so this is not a proper position. If he's going to sit like this, what happens? Automatically postural issues are going to come. So how can we correct this? So we can make them to sit, just so making them to lean on the wall, making them upright, and keep a pillows in between. And then you can give a like, see, they will have chances of exploring the toys. If that is not if that is not working, you can go for corner of the wall. Always that helps, because we have two sides of the wall will be helping you to stabilize the child's body, so that the corner of the wall you can use to adjust and to like what to say, the head and the trunk will be positioned with a wall support, but the legs and all you can make, if the leg is going to be straightened, if it's going to be very much tight or spastic, you can reduce it by using a pillow or bed sheets under the knees. So here already sir told you about the chairs, tables and all which is present for the CP children. So these kind of tables can be used. So here you can see in 31, so the child is sitting upright, right? So here we'll take as a spastic child. So he is having the legs kept it straightened. So if this position is going to be used for all the time, it is going to cause some tightness in hip flexors also, hip flexors and other muscles. So we can reduce those tightness by keeping a pillow or a towel roll or bedsheet roll in between the legs. Or best way is making them to sit in a cross leg. This is also a very simple way to reduce their extended spastic posture. See, you can see a child in 33, picture number 33. So let's take a child is going to be little flaccid. Okay. This child, if they are going to have tonal issues like low tone, so for that kind of children, what can be done? You can correct the posture. Same way, you can make them to sit with the support of the wall, and this kind of like the legs which is spread apart, if they are going to keep the legs like that, what happens, it is going to um, sometimes it is going to lead to subluxations or dislocations. To avoid that, what they are doing, they are keeping some towel rolls just beside both the legs so that they can keep the legs straight. I'll make it fast. Here you can see one child is sitting in the chair. So there are some excuse me. Okay, so this way of sitting, it's not good, right? The posture is going to be affected and the alignment is also affected there. So what can be done? So we have CP chair, right? So along with we can modify it with straps, making them to sit upright. So if we don't have straps, what we do at home? We have some towels or we have some good cotton cloth so that you can tie around the chairs so that the baby will be able to sit erect. So these are all some of the seating devices you can use at home. Um, like what are all the materials you have at home? With that itself, you can make it uh, good material so that we can position them in a good way. For example, you can see here high chair is there with straps to hold the child to it. So if we don't have straps, what we are going to do? We can use any cotton towel or any cloth can be used to tie it. But you have to be sure that you're tying it properly so that it's not going to be like it's not going to work apart from the principles of positioning I told you. Proper stability, the head has to be straight, their trunk has to be straight, the weight have to be evenly distributed. So here we have some standing frames. Usually in therapy, we use the standing frames to make them upright, right? So that we can, for some that time, for 1 hour or 2 hours, for 45 minutes, we are going to do the therapy. During that time, we can make them to stand like this. So this one is the standing frame which helps them to gain their alignment to reduce their postural deformities. So here you can see a child is standing. She's standing, but if you see, her knees are going back, so it completely extended. So this is not the correct posture. So sometimes she will lose the balance. So what can be done? We have to make it correct, right? So what they are doing, they are just using some of the rails. So at home we don't have rails, but we will have window grills, right, to make her to hold and walk, and we can give aids walking aids can be given so that she can maintain a posture and she can walk in a proper way. So without any support, if she is walking, what is happening, she's knees are going back. So if the support is going to be given and properly, and also verbal cues have to be given for this kind of positioning. So with this I end my session. So these are all the some of the positioning techniques that you can be following to avoid the secondaries that is due to improper positions. So thank you so much. Thank you so much, NIPMET team, for giving me this opportunity. Thank you, Mercy ma'am, for giving me this opportunity. Thank you.
Any queries?
Yeah. So participants, if you have any queries, you can ask me now. There is a child who, when sitting on a chair, always keeps his legs up. 18 years. This is not a CP child. He doesn't want to keep his legs on the floor as this is his comfortable position. How can we change this? He is not a CP child, right? So if he's going to be comfortable keeping his legs up, we have to first check what is making him to keep his legs up. So if he is more sensitive to some of the textures, maybe that is making him to keep his legs up. If he doesn't like the floor, the flooring, for example, there are different textures in flooring, right? If he doesn't like, it might be a tactile issue. We don't know. It might be a tactile issue, or sensitive to cold. So this completely depends upon the child only. I think according to the environment they change. If the CP child have the problem, we can say what is the problem. If he's not having CP, what kind of problem he is having? Are you asking for a normal child or child with any other disability? So that is important. So if they are going to have any sensory issues, that can be taken into consideration. So we have to find what is the problem then. If they are going to have sensory issues, we have to address that. Once it is being addressed, we can see. Or else different textures so that you can find it out what is the problem. Her leg are not working. She always use support. She
Child
able
has
to walk
developed
properly.
contractures at ankle, tiptoe. Which position you will suggest in classroom?
What? Has
Child has
developed.
developed contraction.
One person is asking that child has developed contracture at ankle. Which position suggest in classroom? Already the contracture is set, right? So as I told you before, once the contracture is set, it is very difficult to make the joint proper. I'm telling you. So what can be done? You can place a pillow under the knees so that that severity of the spasticity of that contracture effect will be reduced. There's a girl 8-year-old. Her legs are not working. She always use support. Or she able to walk properly? Um, so what is the issue actually? From Urvashi, I'm there is no specific question. So she legs are not working in the sense what she is kind of a cerebral palsy, diplegic CP, or is there any spasticity, or what is the issue? If you tell me, I will be able to answer correctly, appropriately. So is there any queries you have? I'll just wait for 2 minutes. So if there is any questions, you can ask me. Okay. So I think we can wind up with the session. Thank you so much for giving me this opportunity. So over to Mercy ma'am.
That was really an interesting and informative session, ma'am. Thank you so much for sharing your knowledge. Now, we will be having a short assessment on the sessions you have attended. Now, over to the RCA host. Sir, please take over for the assessment. And thanks a lot for the sign language interpreter who have joined us today, Madam Sri Lakshmi. Thank you so much, Madam. May I request the RCA host to take over for the assessment test? Sir, are you there? I request all the participants to stay back. You will be having a short assessment test. I request the RCA host to take over for the assessment test. Sir, are you there? Once again, I request all the participants to stay back for a while till the RCA personnel joins and they will do the assessment. They will share the questions. Kindly stay back for a few minutes. I request all the participants to stay back for some more time. The RCA host will be joining shortly and you will have an assessment test. Kindly remember, people who have registered in the RCA website, people who have submitted the Google form with their payment details, and people who are attending the assessment and clear the exam only will receive CRE points of around 3. So kindly note this. You are supposed to register in the RCA website and then you should have made the payment, and a Google form with all the payment details should be submitted. Dear participants, there is an information from the RCA. The RCA host might join in another 20 minutes. You people can take a small break if you want and come back by sharp by 1:30, even 5 minutes earlier than that. Please take a break. Do not log out. You can switch off your audio and video. You take a break and come back 5 minutes before 1:30. Dear participants, kindly join by 125 sharp.
Okay, so participants, now we'll move to the question answer session. For that, I will on Slido, and when I will on Slido, you all receive a link on your screen. You just have to click on that link and you will join on Slido. And but before that, make sure that you register yourself on the RCA website for the webinar, as ma'am already instructed about this. And please make sure that you make the payment to the institute also, because if you did not make the payment, institute will did not provide your details to us and you will not get the score. So and please make sure your internet connection should be strong during the Slido session. Now I'm going to launch the Slido.
Yes, sir. We have asked the participants to take a small break. Hope
No,
every.
ma'am, I'm just launching the Slido. We will wait, don't worry.
Okay.
We will
Okay.
wait. Yes.
Okay. Fine.
And some participants are saying that they have some issue regarding the payment. So please, will you please clear them?
Dear participants, I have already shared the Google payment account in the chat box. Kindly scroll back and check the payment account number and other things have been shared in the chat box already. Let me try to share once again as well.
We will start the session at 1:30. Okay, now we are going to start the Slido session. And now I'm going to launch the Slido. After that, a link will appear on your screen. You just have to click on that link and you will join on Slido. And please make sure your internet connection should be strong during the session. Okay, so we have total 100 participants on Slido. Those who did not receive the link, they can see a red color button on bottom of their screen. On the left side of that button, there are three dots. Click on three dots, go to the advanced option. In advance, you will see Slido. Click on that and you will join. 103 participants are already on Slido. I request those who did not receive the link or who did not able to join the Slido, kindly go through the instructions. You can see a red color button on bottom of your screen. On the left side of that button, there are three dots. Click on three dots. After clicking on three dots on the top, you will find two sections, General and Advanced. Click on Advanced. In Advanced, you will see Slido. Click on that and you will join. And those who join from the laptop or PC, they can see just after the chat box, there is a participant symbol. And the left side of the participant symbol, there is Slido in green color. Click on that and you will join. 116 participants are already on Slido. We will wait last 2 minutes and after that we will start. I repeat, those who did not get the link, kindly go through the instructions. You can see a red color button on bottom of your screen. On the left side of that button, there are three dots. Click on three dots. After clicking on three dots on the top, you will find two sections, General and Advanced. Click on Advanced. In Advanced, you will see Slido. Click on that and you will join. And those who join from the laptop or PC, they can see after the checkbox there is a participant symbol, and on the left side of participant symbol there is Slido. Click on that and you will join. Around 10 to 15 participants are still left. We will wait 2 more minutes and then we will start. Okay, now we are going to start. So the question answer session is over now. All participants can see their scores on the leaderboard.
Sir, RCI personnel, sir, a humble request, kindly check your chat, sir, panelist chat. Kindly check the panelist chat. I have given a message.
Uh, 1 minute, ma'am.
Our CRE in charge, Manikandan sir, also tried to contact you, sir. Please try to contact him. Dear participants, please stay back for some more time. Please stay back for some more time.
Ma'am, ask Manikanda sir to pick my call. Yes, yes, he's on the.
Sir, can I proceed with the vote of thanks, sir? Is the session over?
Yes, ma'am.
Okay. Thank you so much, sir. So I deem it a great honor to propose the vote of thanks. I would like to propose heartfelt thanks to our director, sir, Sri Nachiketa Rao, our deputy registrar, Dr. Amarnath, sir, for their administrative support for conducting the CRE, I would like to express my deep gratitude to our HOD, Dr. B.S. Santosh Khanna sir, for his moral support and guidance. I am grateful to our Rehabilitation Officer, Therapeutics, Mr. Gurumurthy sir, for his continuous support from the conception to completion of the CRE. I would also like to thank our distinguished resource persons for their excellent presentations, making this webinar information loaded. I take a moment to thank even the RCA host personnel, the member secretaries who have joined today to give the assessment test, and the sign language interpreter for their support. Last but not the least, I thank all the participants for your wonderful cooperation throughout this day. Hope the day was useful to you. Meet you in the next session. Thank you. Thank you so much.
Ma'am, one more thing I would like to announce that when all the participants who are just attending the webinar, they all get the points.
Fine.
Yes, all
Yes.
those who attended the webinar, they will get the points.
Okay. So, dear participants, hope you have understood. Whoever has attended this assessment will get the sure points. Thank you.
Thank you, ma'am.
So, we'll wind up with this. Thank you, sir. Thank you so
Okay.
much.